much. So I'm going to talk about proximal humeral fractures, something which is certainly a difficult fracture for most of us to deal with. My disclosures are the same. So this is a 78-year-old female patient. I thought I'd start with a bit of an audience poll. She lives by herself. She has a few stable medical conditions. She comes to your clinic a few days after having sustained this fracture. So the question I would ask the audience is, how would you treat this patient? So how many people say non-operative treatment? Non-operative treatment. How many people say fixation with a locking plate? How many people say arthroplasty with some type of arthroplasty? So we have a good mix of responses there. I asked this at the American Academy meeting, and I like this answer because basically 1/3 of people said non-op, 1/3 said fixation, and 1/3 said arthroplasty. So that gives you an idea of how little we know what the right thing to do for this patient is in 2019, when there's such a great variation in opinion for the treatment of this fracture. I actually said to this patient, I think maybe you should have an operation for this fracture, and she kind of laughed and said, no, Sonny, I don't think so. And this is her 10 weeks later. So 10 weeks later, she's healed. She has had no surgery. She has 130 degrees of flexion. She has minimal pain, and she's back functioning again. So she did well without an operation, but not everyone does. And our problem is trying to figure out who does and who doesn't. And that's where we are in 2019. We all thought that when proximal humeral locking plates came on the market in 2003 or so, we all thought this would change the treatment of these fractures, make the treatment of these fractures much better, decrease the complication rate, and increase the function of the patients. So that was very much the hope with these angular stable fixation devices, and I used them as well, thinking that they would be a good thing. But in 2019, if we look at good evidence, randomized clinical trials for the kind of fracture I showed you in older patients, and most of the things I'm talking about today will pertain to older patients because that's the vast majority of these fractures. If you look at the evidence, does the evidence support fixing these fractures? So randomized trials looking at fixation versus nothing, just a sling, for this type of fracture. Well, there's 3 good studies that I know of, and apparently there's another one going on now in Brazil that I'll be interested to see what the results are. But the 3 published studies clearly show that fixation in general does not improve the results compared to sling treatment of these individuals, which is kind of a sobering thing for us and disappointing because we thought that we were doing much better than that, whereas in fact we aren't. And the Profer study, the one on the bottom, is a big study. It got a lot of attention in the popular press looking at this as not useful surgery for older patients. And in Britain, where it was done, it definitely changed the needle towards non-operative practice. So people say now, well, we'll leave all these fractures alone and they all do okay. That's not true. They don't all do okay. They all do equally badly. So it's not like everyone is getting a good result and there's no difference. Everyone's getting a very mediocre or poor result and there's no difference. So there's definitely room for improvement there. And if you look at the subgroups involved, the group that has surgery in all of these studies, the group that has surgery, has a good reduction and heals promptly, does better than any other group. And so that's what we should aim for. We just can't seem to get there consistently because the complication rate with proximal humeral locking plates are very high. And no one likes to talk about it, but it's true. And if you look at the studies, that's what happens to some of these individuals. I went back to see why we changed. I used to use a plate like this, which was a small fragment cloverleaf plate, which I'll show you in a second. Why did we change to locking plates? Well, we all changed because we saw a great video of an apple coming off a plate. That was why most of us changed practice. There's no good comparative study saying this is better than the old way we used to do things. One study which was done was a population-based study in New York State. So in New York State, they have a large population database, and they looked at 2 separate time frames in that database. They looked at 1999 to 2000, when almost all the surgeons in the States were using the old style plates, non-locking, maybe a cloverleaf plate or a T-plate for proximal humeral fractures. Then they looked 5 years later when everyone had changed to locking plates. And what they found was, in this comparative study, that the reoperation rate, the complication rate, did not go down. It actually went up, and not by a little, but by a lot, by 50%. So when we all changed from old-style plates to new proximal humeral locking plates, the only good comparative study that I'm aware of clearly shows the complication reoperation rate went up and not down. For that reason, in most places in North America now, and especially Britain, where the PROFER study was done, most patients are treated non-operatively with this fracture. You can see that the reoperation rate is very low. So most of the time we choose not to operate on these patients, and very few ever have an operation. If we do fix them, which is a minority, the reoperation rate in my old province of Ontario was 30%. So 1/3 of those patients had to have a reoperation, usually a conversion to an arthroplasty if they're older. And even the arthroplasty reoperation rate was high as well. So let's just look at a few older cases of mine. This is a fracture dislocation. I think we'd all agree this is a relatively young person. Everyone agrees that this case needs surgery. I used to use the old cloverleaf plate from the small fragment set, and I like that because you can actually capture the tuberosities with the different aspects of the plate. So you can capture the lesser or capture the greater direct fixation to the plate with screws that you're sometimes not able to do with proximal humeral locking plates. And I think that tuberosity escape is one of the biggest problems we have now with these plates. You can't fix the tuberosity directly. Even when you put the plate very high, as we do here, tuberosity escape is still a significant problem because you don't directly fix it. Yes, we all put sutures through tuberosity and fix it to the plate, but there were a couple of biomechanical studies that show really that doesn't work very well because of the high degree of pull or stress on the tuberosities. So what we do now doesn't work. And there's a couple papers I won't show for the sake of time that clearly suggest that tuberosity escape is a major issue with currently available proximal humeral locking plates. Gilles Walsh, who's a famous shoulder surgeon from France, has the same idea, and he says, look at this pictorial. The blue is the locking plate, and you can see it doesn't hold the tuberosities. There's no way to hold them because you're at the side, and you'd like to be at the back or the front or the top to hold the tuberosities. So it's a fundamental problem with the way the plates are designed. People have recognized this, and so these are some of the solutions people have come up with, trying to stack other smaller plates under conventional plates to try and hold these tuberosity pieces together, and that's a pictorial one here. This is another one done from a case close to my hospital that showed stacking a small 1/3 tubular plate with a hook on it to hold a tuberosity fragment that could not be held with a conventional plate. We felt strongly that there was ways to make a better plate that would do this for you without having to put smaller plates on a standard proximal plate. So I'm going to show you that now, and full disclosure, I'm one of the designers of this plate that I'm about to show you. This is a patient who came 8 weeks out with a painful delayed or non-union of their proximal humerus. You can see there's significant varus deformity. The bone quality is not the greatest. I would be concerned if I tried to correct this deformity and hold it with a conventional plate that I would have trouble doing that. And for that kind of case, we developed this so-called hook plate for the superior aspect that will hook into the greater tuberosity and flanges to control the humeral head. So instead of fixing the humeral head with screws, you can cradle or hold it with this type of plate. And that's that particular patient there. So the deformity or the pull into varus is resisted by the nature of the plate and the hook in the top. And this patient healed fairly quickly and went on to develop a good outcome and got back to work within a matter of weeks. This is another patient that's only 34 years old. She fell off a horse, and agreeably this fracture pattern is not that difficult. There's probably a number of ways that you could fix this A2 type fracture, displaced surgical neck fracture. But I want to show you the way we did it with this particular plate, and you can see that just with one screw up and one screw down, that this is a very stable clinical picture here. And then if you look at the radiographic picture, with only one screw up and down, it's a very stable construct. And when you have the plate in place, you can crimp the head, the flange of the plate to actually hold the screw better. Here's another patient with an impacted valgus fracture. You can see the tuberosities on top with a conventional plate out of severe concerns about being able to hold that tuberosity because of the pull on it and the displacement, whereas with the hook type plate, You can see that we've got good fixation, and this patient goes on to heal quickly with good outcome. So this is our idea, and it's a very novel idea. It has not been reproduced well yet. The plate is available at the ITS, is the company that makes the plate here. You should have a look at it if you're interested. It may be a good way to solve some of the problems that we've seen with the conventionally available plates. If you are someone who believes strongly in tuberosity fixation, then I think you might find this is something which is very useful to you. The last thing I'm going to talk about briefly is arthroplasty. So what is the role of arthroplasty in 2019, and why are so many people changing to reverse arthroplasty? And I'll show you a case about why that is. So this is a patient who had a four-part fracture dislocation, and again, she's relatively older, but she's independent, very few comorbidities. So I think we'd all agree that this is a patient who would do well with some kind of surgery. It'd be very bad to leave her in this kind of position. In the past, the standard surgery for this kind of thing is a hemiarthroplasty, and I think that's what I used to do in the past. This intraoperative radiograph shows that the humeral head looks like it's about the right size. It's well centered in the glenoid, and the tuberosity has been fixed to the appropriate position and sewn back into the tuberosity. And when I do these, I sew the tuberosity to the stem of the prosthesis, to the shaft, and then to each other. So there's multiple sutures, all of strong, non-absorbable suture holding the tuberosity in place. This patient comes back to the doctor's clinic about 6 weeks later, and you can see that now we have a major problem. So the tuberosity is pulled off. It's not attached anymore. And the shoulder is subluxated out of joint. And so at this point, this is a disaster for this patient. They have very little shoulder function, and they have pain, and it looks like they're going to need a revision, and who knows how you're going to revise this to make it better, especially when the stem's been cemented into place. And this is the problem with hemiarthroplasty. Hemiarthroplasties are extremely dependent upon tuberosity fixation and rotator cuff. And sometimes, even though you fix them as well as you can, and it looks good, the tuberosities melt away, or the cuff pulls them off, or something happens. And so this is a major issue in about a third of patients who get a hemiarthroplasty. It works some of the time, and it's great when it does, but it doesn't work consistently, and it's hard to tell who it is going to work in and who it isn't going to work in. This is a patient of mine who was 78, fairly active and healthy. You can see here she has a very similar injury, and that she has a fracture dislocation with the humeral head obviously non-amenable to fixation with very little soft tissue attachment. So what do we do for that patient? Now in my hands, the reverse arthroplasty is a much more reliable operation. So my own bias is that this operation is more consistent and more reliable for that patient. Number two is I do repair the tuberosities, and they're probably better if the tuberosities heal, but if they don't, the patient still has a good result, and they're not so dependent upon the tuberosities and the rotator cuff as a hemiarthroplasty is. So it's a much more forgiving operation, and what it does is it narrows the bell curve of outcome to a more consistent and reliable outcome in the good or excellent range. And this patient had essentially a normal shoulder, the tuberosities healed well, and the patient did very well. But even if they don't, then it's still a good outcome. And there's a small randomized control trial from Spain looking at hemiarthroplasty versus reverse in this exact kind of setting, and the reverse group was clearly superior. It wasn't very big, only about 60 patients, but the patients who had the reverse did better in terms of flexion, they did better in terms of less pain, better function, and a fair number of the hemiarthroplasties had failed tuberosity fixation and had to be converted to reverse. So I like that study because it kind of caters to my own bias, which is that the reverse is a better operation in general for an older patient with a non-reconstructible proximal humeral fracture. So to conclude, I'll say that most patients in 2019, with the evidence that we have right now, most elderly patients can and should be treated non-operatively with proximal humeral fractures. Currently, there are 3 well-done, large randomized controlled trials that show we really can't do better than a sling with the conventional plates that we have at the present time. In my own opinion, and obviously I have some bias there, there are definite improvements that can be made in the plate design to capture the tuberosities better and reduce the rate of mechanical failure in these patients, because if you can do that, then you can produce a reliably and consistently better result with fixation than a sling, if you look at subgroup analysis in the randomized trials. And lastly, I think that the reverse has significant advantages over the hemiarthroplasty in 2019, and there's some early papers out there that would show that's the case. And at the very least, if you are going to do a hemi, you should use a platform stem that can be converted to a reverse easily if there's evidence of tuberosity failure and rotator cuff failure afterwards. Thank you very much for your attention.